Dr. Ichaporia, sir, with your permission, shall I go live, sir?
Yes, it's 8:30, so we start.
Perfect, sir. Thank you, sir. So good evening, everyone. I am Dr. Sanket Nivale, representing Medical Affairs at Emcure Pharmaceuticals, and I welcome each and every one of you for the 4th episode of No Thrombosis Workshop Series in Acute Ischemic Stroke. With great pleasure, I would like to introduce our course director, Dr. Ichaporia, sir. Sir is a director, neurology at Sahyadri Hospital, Pune, first neuro ICU and neuro intensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India, more than 300 public lectures and workshops on stroke. Member of the Indian Stroke Association and the organizing president of StrokeCon 2012, the organizing president of ISA's Stroke School, ex-president of the Society of Neurosciences, Pune, and ex-president of Maharashtra Academy of Neurology and founder of the Pune Stroke Group. Principal investigator for multinational stroke trials like Perform in stroke, BG12 in MS, cortical venous thrombosis, BrainsGate, stroke, Interact 2 with cerebral hemorrhage. Recently awarded as a health icon by the Times of India Group. So we welcome you for the event.
Thank you so much.
We have our moderator today, Dr. Rajsekhar Reddy, sir. Sir is a director, Max Institute of Neurosciences, Max Super Speciality Hospital, Saket, New Delhi. Sir is a Fortis Hospital Ranbaxy Group company and has been attached since January 2005 to May 2006. To 23 publications in national and international journals and participated as a speaker at multiple national and international platforms. Sir, we welcome you for the event.
Thank you everyone. Pleasure to be here again and with Dr. Ichaporia. Thank you.
We have our guest speaker today, a guest moderator today, Dr. Vijay Chenna, sir. Sir is a consultant neurologist at KIMS Icon Hospital, Visakhapatnam, life member of ISN and APNSA, poster and oral presentations at multiple conferences, 5 gold medals during his MBBS tenure, multiple publications in national and international journals, written a chapter on intracerebral hemorrhage in Neurovision Update 2019. Lectures have been delivered at multiple conferences. Sir, we welcome you for the event. We have our first speaker, Dr. Nilesh Palasdevkar, sir. Sir is an assistant professor of neurology at BJ Medical College and Sassoon General Hospitals. He owns and practices at Brain and Spine Clinic, Pune, attached as a consultant neurologist at Noble Hospital, Sahyadri Hospitals, and Ruby Hall Clinic. He has publications in national journals. He has presented papers and posters in many national conferences. He is invited as a speaker in various state and national conferences, and is actively involved in public awareness programs to spread knowledge about neurological disorders. Sir, we welcome you for the event. Our second speaker today would be Dr. Lomesh Birud, sir. Sir is a consultant and interventional neurologist at Ruby Hall Clinic. Dr. Lomesh Birud, sir, has been trained to do cerebral angiography, mechanical thrombectomy for acute ischemic stroke patient, aneurysm coiling, carotid angioplasty and stenting, intracranial angioplasty and stenting, and various neurointerventional procedures. Sir, we welcome you for the event. And with this, I would like to hand over this to our session to our course director, Dr. Ichaporia, sir, for the context setting. Over to you, sir.
Thank you, Dr. Sanket. We've had some absolutely fascinating cases which we discussed over the last 4 meetings. This is the 4th, no? Yeah, over the last 3 meetings. And we were really delighted to have a cross-section of people, doctors, very, very knowledgeable, young, aspiring neurologists, neurosurgeons, and they've done an absolutely wonderful job in presenting some wonderful cases. So I'm sure we'll have a similar session today, and we are very happy to have Dr. Vijay Chenna as a moderator. I think this is your first time, Dr. Vijay, in our program.
Yes, sir. This is my first program.
Yeah. I'm sure you will enjoy it. And I'm sure we will learn many things from you also. And everyone has to learn from each other and exchange ideas and thoughts. And that is the actual purpose of this no thrombosis. This thing. And I think we've had, Sanket, we've had large audiences for the past 3 programs.
So on an average, we had between 200 to 300 attendees almost on every program that we did, sir.
Yeah. So it's been a very popular learning tool for all of us. I'm sure Raj Shekhar agrees with that. I think he's also delighted to be on the show. And this is the 4th time we are together. And I'm sure he's very happy to be on the show also tonight.
Absolutely.
Raj Shekhar, you want to say something, please?
Absolutely, sir. It's been a fabulous last 3 programs. And like you were saying, we see some common cases and we see some difficult cases. And at each step, we kind of discussed what could be done and what should have been done and the different options. And I think it was a great learning experience. It's like, it sort of broadens your vision about and tells you that something that looks so mundane and so ordinary, there are so many nuances, so many subtleties that come to fore when we discuss in such a forum. So it's been fabulous, and I'm sure that we'll continue that same tradition today also.
Yes, I'm sure. Now, may I request Dr. Nilesh Palasdevkar to present his case. Nilesh is a very dear friend of ours. He's working, I would say, in a rival hospital. But we are not rivals. We are great friends. The hospitals are rivals. So, Nilesh, I think you can go ahead with your case.
Right, sir. Right.
Yeah.
Thanks, Ichapuria, sir, and thanks, Emcure, for this opportunity. Is my screen?
Yeah. Can you make it full screen somehow?
Yes, I have made it full screen.
So we can see it full screen, sir.
Yeah. Okay, fine.
Right. So basically, this is a case of young woman, a case of young stroke, which presented to us say around some 3 months back, right? So she was this young lady, 27-year-old, absolutely healthy prior to this, no other comorbidities. And one day in the morning hours, she presented to us with the right side weakness since last 3 hours. And there was some difficulty in speaking with some facial deviation. So when she was brought to us, her blood pressure was 126/80. The peripheral pulses were well fed, around 70 per minute. They were regular. And she was having a dense hemiplegia. She was totally disoriented. Her eyes were deviated to one side. And then she was totally aphasic, confused. And her NIHS score that time was something around 20. So with this, she presented to our casualty within 3 hours. So she was in the window period. So we announced a stroke code and a stroke imaging was done. And MRI was done, and the MRI showed a large developing left MCA infarct. There was diffusion flare mismatch was there. It was an hyperacute infarct. We usually don't do perfusion studies, but then it was a hyperacute infarct. Along with our protocol, we did a CT angiography. The CT aspect score was 5/6. So, and then we did a CT angiography which showed that there was a thrombotic occlusion of the left M1. And the prior collateral scoring was intermediate. So we had this young lady who came with a large MCA infarct with NIHS of around 20 with CT angio showing a large vessel occlusion. So according to our hospital stroke policy, we thrombolized her in the casualty itself within window period, and the thrombolysis infusion was started. And immediately after explaining the relatives taking the consent and obtaining adequate
window period means what? Window period means what?
Sir, she was thrombolized in next 45 minutes on her arrival. So probably she was thrombolized in 3 hours 45 minutes from the onset of the stroke. So we could give the bolus within 45 minutes of arrival to our casualty.
Okay. Okay, carry on.
Right. Yeah. So then we, after, taking the permission of the relative, she was young and there were too many people who had come with them. We counseled her for the angiography and she was taken in the cath lab for a DSA. So this is her pre-thrombectomy DSA. If you can see the left, there is complete cutoff of the left M1 and it is can't see beyond the stem of the MCA. However, the distal circulation is still maintained. That was due to basically the collaterals and the pile circulation. So our intervention neurologist, radiologist, Dr. Shrikant Londe, took immediately for a thrombectomy, and a thrombectomy was done. And if you can see, a very successful thrombectomy was done within the 2 passes, and the collaterals filled beautifully. So we thought that we had done a good job. The door to puncture time was slightly on higher side because of the procedure involved, but the door to puncture time was something around 90 minutes and the vessel was opened in next half an hour. So there was a good circulation which was formed and we expected a good result. However, we, as all radiologists or the intervention guys, they did wait for some time, and after some time they found that the vessel again collapsed. There was a very thin circulation which could be visualized, and there was collapse of the vessel, and then an underlying dissection was noted. So he started her on tyrofibon. Initially also we had given a bolus of tyrofibon, and with Actilize was also given. In spite of that, there was this dissection and the vessel was continuously collapsing for next half an hour, and again the collateral circulation which was there, it was suffering. So looking at this scenario and keeping the vessel patent was utmost importance. So what we did, he did a stenting. So a stent was put across the dissection, and then we waited for almost another 30 minutes, and the collateral circulation after post thrombectomy was maintained. So whole procedure, it lasts for around 1.5 hours. So almost after 5 hours after the onset of the stroke, we could reperfuse the blood to the brain. Post stenting, post thrombectomy, CT scan was done and it didn't show any reperfusion bleed. So the patient was shifted to the ICU. She was monitored. She was still aphasic and she was still hemiplegia was still there. So next day morning, what we noticed, that her right lower limb, that is the paralyzed limb, it was totally cold and clammy. The peripheral pulses, they were not felt. And again, the patient was taken to a CT angiography of the lower limb. And this time it shows that there was a thrombotic occlusion of the external iliac artery. A vascular surgeon was involved, and this was new to us. She required an embolectomy and fasciotomy needed to be done. Neurologically, she was sedated for that day, and we couldn't really couldn't assess what was the neurological status. We started the stroke workup, and now there was a LV clot, and her ejection fraction was just 40%. The cardiologist, he diagnosed it, and this was the LV clot probably which had embolized and led to that M1 occlusion, and he diagnosed it something as the LV non-compaction syndrome. Her hemoglobin was also on the lower side. The platelet counts were also on lower side. However, the rest of the workup, like the APLA antibodies, lupus anticoagulant, they were negative. We transfused her 2 points of blood. We sent the blood for antiplatelet 4, thinking whether it was some kind of post-COVID manifestation. However, her antiplatelet 4 antibody was negative. A hematologist was consulted, and he started her on low molecular weight heparin. Actually, he had suggested on fondaparinux, but as we all we had discussed a similar case in large no thrombosis meeting, and that time it was we had all come to conclusions that in such cases, even if the vaccine induced or COVID induced thrombocytopenia, coagulation state is suspected, still low molecular weight heparin is a better choice. So we started with low molecular weight heparin. She had a large infarct. However, surgery was avoided. Over a period of next 1 week, she did quite well. To our surprise, she started speaking, swallowing within 1 week. the power on her right side, it improved to almost 3+, and she was able to walk with minimal support in our ward itself, and she was discharged on rivaroxaban. On recent follow-up, she is almost asymptomatic. Her speech is improving. There is some amount of anemia and dysarthria, but most of her language dysfunction has improved, and she is almost independent. On the recent follow-up, she was almost modified Rankin scale 2. So this is a case, young stroke. She came with this thrombotic episode. So we thought that there was two pathologies. One was the dissection. We really don't know why that underlying dissection was there. And secondly, she had got this underlying thrombogenic state, which led to this LV clot, which led to the thrombosis of the lower limb artery and probably to this stroke. So in spite of this thrombolytic and tyrofibon, this vessel was still collapsing. So sometimes in patients who have got this local dissection and there is recurrent collapse, or stenting might be required. We also suspect that some underlying thromboembolic state, whether it was temporary or it might be some other thing, though our whole workup was negative, it might be contributory. So this was slightly difficult case of young stroke with multiple thrombotic events in her limbs as well as the heart. Her follow-up 2D echo showed that LV clot was not there, and her ejection fraction also improved. That's it. Thank you. Yes, sir.
Yeah, very wonderful case, I must say. Dr. Chenna, would you like to comment? Dr. Chenna? I think we lost him.
Sir.
Dr. Chenna, yeah.
Very nice case, sir. But there were a lot of complications there.
Yeah.
Interesting one. Sir, regarding bicytopenia, sir, or is it a pancytopenia in the patient we had, sir? Or,
we had bicytopenia. Her WBCs were normal.
Normal.
Yeah.
So, any workup on that, sir? Conclusion was there. What is the cause of bicytopenia?
Sir, actually, during the later stages, after 2 weeks, her platelet counts also improved, and she didn't require any of the hemoglobin. The hematologist was planning to do a bone marrow because it improved by itself. So they thought that it was something transient phenomenon. So they didn't work up it further. And she was also on this anticoagulant. So bone marrow was deferred for some time.
So in this, the management wise, there is no doubt, sir. What we have done was done according to the protocol. So here comes only the problem with the follow-up treatment, whether you want to go on with anticoagulation or antiplatelet, because it is a stroke in end, and the etiology has not been at conclusive of what is the cause of LA clot or bicytopenia. So how did you go on with the further management, sir?
So basically, sir, because we had a LV clot and she had got a sudden cutoff of the M1 segment, we thought that it was an embolic stroke only, and there was no other disease, atherosclerotic disease anywhere else. So currently we are continuing her according to the hematologist advice, and because there was no atherosclerotic risk factors, so she is on anticoagulation only, sir, not on antiplatelets or statins.
So only anticoagulants are going on.
Yeah, currently only rivaroxaban is going on.
So any vasculitic profile was done, sir?
We did her, sir, ANCA, we did her lupus anticoagulant, we did her ANA block, and we did her APLA profile. So that everything was negative, sir. And even on the DSA, they felt that there is no other CNS vasculitis as such. It was only the M1 which was occluded, and no other string sign or beading pattern was observed.
Yeah, we also had a sir.
Yeah. Okay, Dr. Vijay, please continue. Sorry, I interrupted.
We also had a similar stroke, sir, but we had a TIS as the presentation. So we didn't. We were in a doubt whether we need to thrombolize the patient or not. The MRI is the same. We had an M1 occlusion which was present on the left side. It was a very long occlusion, but the distal peripheries were being filled. On diffusion restriction, there was only a mild restriction which was present, but NIH's was only one. Has improved even that with 1 hour. So we did an DSA. DSA was also confirming the same. CT angiogram was done, which is also confirming the same, that there is a long segment stenosis was present. So with our interventional radiologist, we thought of stepping back rather than doing a stent there, because there were a lot of chronic infarcts which were present in there. And so we stepped back. So after that, my boss was Dr. Subhash Kaul. So we sent him there to Hyderabad. There, sir was also telling that we could, that was the one which were better. We have worked up him from vasculitis, we have worked up from all the thrombotic workup, everything was negative. So there we went on doing a vessel wall imaging, sir. So where we found that the M1 segment where it was critically stenosed, it was more than 90%, it was showing a significant vasculitis present there. So and the remaining vessels were completely normal. It is a single vessel which was involved in the patient. So there, this was my experience of a patient, and he being a radiologist, so we were very lot of ambush was there whether we need to do a stenting or not. But luckily enough, with the help of sir, we didn't do it. So what he was telling, that if you would have done that, it is a very chronic thing there. It would have gone the same way as sir had a, while doing the thrombectomy and the stenting, it was collapsing. You would have a collapse and a dissection would have happened. So now with immunosuppression, he is completely doing good. He is now 6 months down the line, he is doing good. He has no further attacks at all.
I will plan a vessel wall imaging in this case.
Yeah, vessel wall imaging would might help for her.
Right. We are doing it in few cases.
It's a clear-cut. It is a clear-cut embolus. I mean, where's the question of vessel wall imaging in this case? I mean, there's an LV thrombus. There's the M1 occlusion. There's an occlusion of the external iliac. So it's clear-cut embolic. That's what I think. I don't think it's ICAD or vasculitis or anything like that. Rajshekar?
I think, sir, I completely agree with you, but I also think that what's happening here is possibly they're worrying about the dissection aspect of it, whether that particular aspect can be explained just by a prothrombotic state. So I think because that has come into play and was part of the pathology, the major pathology, where they have eventually had to put a stent because it kept collapsing. So maybe that dissection in this setting is what made them think. So an accelerated APLA syndrome, for example, what is called Sneddon syndrome, can present with a catastrophic prothrombotic state causing multiple occlusions in different parts of the body. And I'm just thinking that because, even if she did have an LV thrombus to embolize to one vessel one day, to the brain the other day, I mean, you have to be grossly unlucky for that to keep happening so fast. Even with people with non-valvular AF and long-standing LV clots, we of course, we don't see them having so many events at the same time. So yes, the post-COVID state comes into play. Now, in the dissection part of it is the interesting part, because if there's been some, intracranial dissection, the etiologies of that should be looked at separately. I think we'll have to look at that and see what are the causes of dissection, why is there dissection happening in this, and then look at the other pathologies and try to put it together. So I think it's interesting. One of the difficult things is to have a young person who comes in with such a stroke, because anybody with a stroke, of course, is very valuable to us. But a 27-year-old lady who's going to become aphasic, and if you don't open out this vessel, is going to end up having a hemicraniectomy. And that kind of situation is, of course, a major concern for all of us. So interesting case, and I think it was handled very well. And we've also seen that many people with these strokes, eventually they tend to gain a lot of function back, even though they seem to, at the beginning, seem to have a significant amount of deficit in terms of speech loss and all that. Over the next few months, a lot of these people have a large gliotic area in the cortex when you follow them up. But they sometimes, because of, again, neuroplasticity, etc., tend to gain a lot of function back. So it's always, and this is the thing you've done, you've saved the brain here. Very good work.
Thank you, sir. Thank you. Thanks for your input, sir.
I was thinking that dissection was traumatic, or it was not there in the first angio.
Yeah, yes, sir.
It was after the intervention.
Right, sir.
So mostly it is a traumatic thing. It's not de novo.
So that's interesting, sir. So, if the moment you say that if there is an intervention which caused the dissection, then we're not worrying about that at all. Then, of course,
I
that
think
physiologically is not
the CT angio didn't show it, nor did the first angio.
And that's a very plausible explanation, that when you're trying to do something there, you inadvertently cause a dissection, and then you have to deal with that problem. So
I think it was that,
Probably if Lomesh
it's
is
a
there,
well-known complication.
If Lomesh has joined, probably he can help us with that.
Yeah, maybe he can. One or two things I want to make a point.
Right.
Nilesh, why do you do the MRI and then you follow it up with the CT angio? Why do you use that and waste time?
Sir, currently, sir, that is the protocol that we are following at here. Basically,
But
sir,
which is protocol?
Yeah, that protocol, our intervention is, and everybody. Basically, MRI is for the volume and the infarct, and CT angio is for the
Why
vessel.
do you need to see the volume? I mean,
yeah.
See, clear cut. There is a hemiplegia with aphasia.
Right.
The NIHS is 20.
Right.
Straight away do a CT and with a CT angio. See, you've wasted another 15 minutes here.
Right, sir. Right.
Easily 15, maybe even half an hour. So I mean, we don't do this. We don't do an MRI followed by, and it increases the cost, increases the time. So I don't think it adds value.
So we begin with the CT, then CT angio, and while shifting, we get an diffusion MR. But as you say, I do agree that it takes whatever we say 5 minutes.
Yeah. I don't think it's necessary. I think you need to change your protocol, because it's see what happens. Then you don't give the thrombolytic agent in the CT scan department itself. So easily you could have, instead of door to needle time of 45, you could have brought it down to 20. Right. In fact, when you do the CT scan, even before doing the CT angio, you can give the thrombolytic agent. So you could have done it in 15 minutes.
Maybe.
And 15 minutes, we've seen many patients on this forum also, and also in real life, that when you give early, your recanalization rates are much higher. So I think, and many people are doing this. Unfortunately, and Rajshekhar has also pointed this out umpteen times, and we have discussed this in great detail. I just can't understand why everyone is doing MR followed by CT angio, and wasting half an hour. It's a very valuable time, and so I think many of us will need to. I don't want to be harsh. I don't want to be critical, but I think we need to get this very straight. Rajshekhar?
Completely. I cannot agree with you more, sir. I completely agree. I think we say that if you want to waste brain, do MRI. At least for now, that is the philosophy which is there. I know that there are people who advocate quick sequences, fast MR sequences, modified partial studies where you do a SWI, you do a GRE, and or a DWI and an EDC. That's all you need to do, and a flare. But even that takes time. I think getting a patient into that MR machine, putting him in the gantry, it takes a lot of time. And I think that once you have a CT scan, if you're not seeing a big bleed, if the patient has no major contraindication, that is the patient for an IV thrombolysis. That's all. I think beyond that, regarding any kind of mechanical intervention that you may plan, again, the aspects and all will come into play. But I think for IV thrombolysis, even that may not be a big concern unless, you're clearly seeing a massive infarct right very early on CT scan. But in this period of time, you've already seen nothing which there you go ahead and thrombolize and I think most people, like Sir said, will do very well. So I completely agree with Sir on this. I don't think MRI should be done.
Nilesh, there's no need to do. The patient is in the window. You don't need to do diffusion flare mismatch. It doesn't make sense. The diffusion flare mismatch is when it is time of unknown onset, stroke of unknown time onset, or wake up stroke, and you don't know the time. So then you want to do flare to see if there is any flare change. But when she's come early in 3 hours, you don't need to see that. I mean, you're wasting another 5 minutes or 10 minutes doing the flare. So it doesn't gel. It just doesn't gel. Dr. Vijay, you have any comments on the imaging?
No, sir. The point is definitely valid. But if my approach is that we don't have a CT perfusion technique in our thing, so we do.
You don't need a perfusion. When the patient has come in 3 hours, why do you need a perfusion? Perfusion is required if it's a late time window. You don't need a perfusion when he's come in 3 hours, 4.5 hours. You don't need it. So you don't need sophisticated equipment. You need sophisticated equipment only when you're doing it outside the window period. I mean, window meaning 4.5 hours.
Okay.
Yeah, but for early cases like this one, you don't need all that. So, time is of the great essence. Everyone says tissue is brain and time is not important. That is absolute nonsense. Time is important. It's vitally important. So I think we need to stress this point. We've discussed it many times, but I think every single time we need to stress this. And, everyone, especially the interventionists, say that, no, tissue is brain, time is not brain. But no, both are important. Time is brain, tissue is also brain. So both are important. So, but also, Nilesh, I'm a little intrigued. How much was the platelet count you said?
Initially, it was 60,000. Then, in second, we didn't do a CBC initially. It was after everything, the reports that came. Then it was something around 20,000 on the third day. And then all this immune thrombocytopenia, all those things started coming up.
But had she taken the vaccine?
Not recently, sir. She
didn't because in young women, this what is this VITT thing? It occurs within from 6 days to 40 days or something like that.
Yes, sir. There was no recent history of any vaccination.
Yeah, so it's not vaccine-induced thrombocytopenic thrombotic thrombocytopenia.
So that thing was thought of, but that anti-platelet 4 was sent, but it came negative.
Yeah, so it's not that. Now the purists will say that how did you thrombolize when platelet count was so low? But we don't wait for the platelet count. We don't wait. I mean, this was unusual.
She was absolutely healthy, sir.
Yeah, so that's amazing. See, and this thing that platelet count should be 1 lakh, otherwise you should not thrombolize. Now, who has done a study? Nobody has done a study. This folklore. This is folklore. Now, here in this case, it was 60,000, and she never bled.
She didn't bleed, sir. Never.
Yeah. So we'll need to revisit that. I mean, it's shocking. It's little worrying also.
Right.
60,000 and then coming to 20,000. My God. And you're giving tirofiban, you're giving dual antiplatelet. Maybe you've given Brilinta also. Brilinta was given?
Brilinta, sir, post-op she was on Plavix. Not Brilinta, on Plavix.
Plavix, okay. So high dose Plavix, loading dose, tirofiban, heparin, aspirin, and platelet count of 20,000. Even then she didn't bleed.
Yeah. This is... So I think, I completely, that's what it's amazing that sometimes we get away, because if we had seen these parameters before we started the procedures, we would have probably held back everything.
Yeah,
It's a good thing you can't. We
exactly.
don't have time to do this sometimes, I think that the thing is that, again, it comes to mind that this is probably a case where there is some, you're seeing a state where there is a coagulation disorder happening, where there's coagulopathy along with thrombocytopenia. And again, some of these accelerated antiphospholipid antibody syndromes and many of this DIC kind of picture where they are mimicking DIC are going to look like this. So I'm just thinking, then, and as that thing goes away, once that acute catastrophic thing goes away, then the platelets start picking themselves up and going away. So something which is probably inciting that event. And this woman was never on a oral contraceptive or anything, was she?
No, sir. No, sir.
All right. Okay.
Did she have any abortions in the past, Nilesh?
Sorry?
Any abortions in the past?
No, sir. There was no history suggestion of any Atlas syndrome, sir. Any other thrombogenic
But it
events.
sounds very much like a accelerated APLA, Rajshekar.
So we will probably need to follow up. She just
because she's a young woman. She's got a thrombus in the LV. Why should somebody get a thrombus in the LV?
With a normal ejection fraction.
Unless you had an infarct or myocarditis or something like that, de novo, out of the blue, why should you get an LV thrombus? I mean, that's also something. So obviously there's some procoagulant situation.
She will need some follow-ups, right?
Yeah. And during the acute phase, whenever we assess for these factors, many of them may be falsely, erroneously low because they actually get used up. So you must do it again after 6 to 12 weeks to try and see what it looks like at that point.
Yeah, exactly. And another point I wanted to make was, I've always been in a little quandary. LV thrombus, should we give warfarin or NOACs? Is there any study to show that NOACs are useful in LV thrombus?
Sir, according to one of my cardiologist friend, he feels that vitamin K anticoagulants are better. That is what
the studies are with that. As far as I know, maybe there is a recent study, I don't know. But as far as I know, LV thrombus, there's no study with NOACs.
I completely agree again with you, sir. This is, this for conventional anticoagulation is the way to go when you have an LV thrombus. If you have a very tight MS or a severe MS, you would want to go. Other valvular diseases, they're trying to stretch it now to use NOACs, etc. But I think for this situation also, you would be much more better off using it. It is conventionally we should go with warfarin. I agree with you on this.
Yeah. Nilesh, do you have a post thrombectomy scan?
So we had done CT scans. I don't have it right now, sir.
Yeah, but you know what Rajshekar was saying, and I've seen this umpteen times, that the infarct is big, but the fellow is walking.
Right.
And he's speaking, and he's moving the upper limb also, and there's no hand dystonia or hand weakness. But if you see, there's a big encephalomyelitic lesion and a big infarct.
Absolutely.
So, and I've seen this umpteen times, and I don't know which part of the brain is working. But it's amazing how it happens.
So on the second day, I explained the relatives that there are hardly any chances that he will come out of this.
Yeah.
He was on a ventilator, sedated, that thrombus, and the cost was enormous, sir.
Yeah.
Thrombolizing,
the cost must have been 20 lakhs.
Of her leg, and all the investigations, and then but the moment on third, fourth day, she started improving, and then the relatives also were slightly more better, and we were also more confident that she might come. Otherwise, on the second day, sir, almost we had thought that now it's the end of it.
Yeah.
I had said that the chance is just 10 paisa.
You are working in a rich hospital. No, we are not so lucky. Yeah.
No, sir. We tried to help her as much as possible, sir. At the end, they were totally drained of village folks coming from the interiors. Frankly, we did help her as much as we could.
How much do you think the bill was?
Sir, the bill was around 10.
10?
Yes.
You got off lightly. See, thrombectomy, stent in the carotid, tirofiban, embolectomy, fasciotomy, 10, you are lucky. I think it will be 20. Yeah. Rajshekar, what do you think? Your estimate?
I agree with you, sir. 20. I think that's the minimum I'd go with.
But it was around 10, sir. And later she also
Very good,
developed
yeah. Very good.
that embolectomy wound. She developed an infection, so we had to keep her for some time more. But then
And ICU, ventilator, antibiotics. My God. Anyway, you've done a wonderful
A great
job.
job. I know. Wonderful job.
And we congratulate you wholeheartedly. Very, very difficult, very interesting case. Dr. Vijay, would you like to say something?
Only one more doubt, whether any history of 2 weeks prior, any viral illness or something which would have caused some viral myocarditis, LV thrombus, and like this.
So specifically, sir, we didn't probably, but there was no such antecedent history. That is what I remember. Yeah. Yes.
Maybe that was one possibility where you can explain such things, whereas a viral infection could have caused a bicytopenia and heart myocarditis and an LV thrombus, which would have embolized both the leg and also the brain.
Yeah.
Right.
Thank you. I think we've discussed this case threadbare and all points. Anything else you want to say? Nilesh, you want to say something more?
Yeah. Many things for me to learn.
Huh?
Many things for me to learn. That is all. That all.
We are also learning. Yeah.
Yes. Yes. Even last time, sir, the case which I discussed, that also probably it was a VIIT case, and it was a young girl who developed this bad CVST, and then she couldn't survive.
VITT. Right.
Yeah. Dr. Sanket, is Lomesh around?
So I've been trying with him, sir. Not responding. Probably still busy in the case, sir. Tried on the mobile in terms of network call as well as with the WhatsApp call, but no response from his end. So probably we would have to curtail to only one case today, sir.
Okay. Let's see. Dr. Vijay, do you have any case to show offhand or anything to discuss? We've still got some time.
Regarding, I just want to share my experience during under Dr. Subhash Kaul. I have done my thesis on thrombolysis, but the drug was Altiplase at that time. It was from the period of 2010 to 2015 data, which I analyzed for the predictors of the ICH in thrombolyzed patients. So we have studied around 115 patients. So because we were discussing previously that the platelet count was 60,000, we have thrombolyzed, but the patient did not have bleed. So even in our study, we did not find any factor related to the platelet count or the hemoglobin. Only thing, the coagulation parameter which was significant was INR. So that was anyhow, we have it in our guideline that more than 1.7, we should not thrombolyze, we should correct it, and then only we should thrombolyze. But the major important factor which we found was 4.5 hours more. The longer the duration, the chance of bleed is the more, which was a standard thing that we have also found the same. And the presentation, at the presentation, what is the hypertension? The blood pressure recording. So if the higher the blood pressure recording, the chance of bleed post thrombolysis was a very significant thing. And also the sugar levels, the diabetes, if prior diabetic, and at the presentation, if sugars were around more than 250 or 300, then also we found that there is a significance for the post thrombolysis bleed. So these three only were found very much significant. And the platelet count and the hemoglobin was not significant according to the data and analyzed among the 115 patients we have seen.
What about size of infarct?
Yes, sir, size of the infarct. That was also the four points. Size of the infarct, duration, and the presentation, blood pressure, and the sugar levels. These four were very much important.
Yeah, I've had one, patient like this in the sense, she was on chemotherapy and the resident doctor didn't take that history and she gave thrombolytic therapy, Actilase, and later on the platelet count came to 15,000. So, but God is great. She never bled. That patient didn't bleed. So, so many things are written in the guideline, but they've not been substantiated in actual practice. The guidelines were written so that it was safe. It was presumed that platelet of 1 lakh should be there. But there has been no study to show that you need it to be 1 lakh. So, many of these guidelines, I think, may need to be revisited or rethought of, because the studies were done, all this NINT study and all done in the 1990s. They just put it arbitrarily. These are arbitrary levels. Now, even this 1.7 warfarin, INR, I don't know if there's a study for that, or, it's just an arbitrary figure. Is there a study, Vijay, or it's just an arbitrary number?
It's from the NIMS guideline only, sir. It was followed from them. There, where they found that more than of 1.7, especially when these were noticed with rheumatic heart disease patients where already they are on acetrom or warfarin.
Yeah.
So in those patients they have studied, sir, and they found that this would be the value where we need to cut off.
Yeah, I know. So maybe we'll have to rethink. Rajshekar, you want to say something on this point?
No, I think, what happens, I think at times of inclusion and exclusion criteria, when they are doing preliminary work for these drugs, they try to keep a number beyond which they think possibly they look at safety, and they say that, okay, beyond this, we will not do. So they probably don't include patients with these numbers, and hence they can't comment about these numbers. But I think there are only 2 reasons why you would not thrombolize. One, the patient has an intracranial bleed. And the second, the patient has come out of the window period. These are the 2 things that would stop you from doing IV thrombolysis. Other than that, really everything else is a relative contraindication. So we know that absolute contraindications are only these 2, and everything else is relative. So relative means that, you use your judgment, and if you think that the patient is going to benefit, we go ahead and do what you think is correct for the patient. So I think that, interestingly, actually, it seems like I'm creating an anecdote, but I would actually discuss 2 interesting cases in the last 2 days. Today, I had a patient who came to me, 83 years old. He had had a stroke about 15, 16 years ago when he came, and I saw him late night, completely hemiplegic. He was about, at that point of time, 4.5 hours into a stroke. And those are the days when 3 to 4.5 hours, we were not thrombolizing patients. We took him straight for an endovascular procedure. At that point of time, we used pro-urokinase, and we thrombolized him. We did a mechanical, whatever. There was no mechanical thing. It was just intra-arterial at that point. And I remember Dr. Vipul Gupta and myself, we were there till about 4 o'clock in the morning. And then we left. And this person had come with a dense hemiplegia. And next morning at 10 o'clock, we arrived because we'd had a really long night. So we came back at 10 a.m. And this person was reading a newspaper. I will never forget that. And when I walked into the ICU, this person was sitting there reading a newspaper in the morning. And after that, he went on to play golf, and we published there was a write-up about him in a local newspaper, in the Times of India, actually, where they showed him playing golf and saying, this is what happened after a stroke, etc. This is way back, 2005-6, I'm talking about. And he came back perchance today for some other reason, just as a follow-up for some other mundane reason he had seen me. And he said, I've done a CT scan just like that. And while you were mentioning, he had this area of glaucus. And interestingly, this is a right-handed person. He's got a left MCA territory score, large area of glaucus, absolutely no deficit. And now, no speech, nothing, absolutely. He's a major general in the army. I won't divulge his name, but I'm just saying that these are the things that sometimes you learn. And there's another patient who was admitted under me recently, about 6 days ago.
Rajshekar,
Yes, sir.
has he mentioned you in his will?
I'd happily take that any day. So this man, and he's such a wonderful person, and he keeps confidently sending. I don't think he realizes the magnitude of what has happened to him. Sometimes people think that, okay, this is, people recover from a stroke and they think, oh, everybody gets better kind of thing. Sometimes people don't, we only see, my God, this is, he was 66 then, he's 83 today. And it's amazing to see that. So another lady, I just had a 47-year-old who was admitted with a transient left hemiparesis in Meerut. And they called me from there saying that, she had a stroke and she's recovered completely and we're coming to you. So we come, 47-year-old AVR, and she's got a metallic valve. Way back in 90s, she's got a metallic valve. So we can't do an MR and we talk about this and that, maybe doing a 1.5, but she's got no deficit. So we do a CT angio and she's 1 day post the event, so there's no rush. And she has a significant thrombus in the right distal ICA all the way to the MCA. But she has no deficit. So she's been on anticoagulation, conventional, because of the aortic valve, inadequate INRs. So I decided, look, I'll have to put her back on this, but for now, for whatever it's worth, I'll put her on low molecular weight heparin. I know that it seems less, but let me do something so that I can get it up fast. And she is 120 kilos. So I put her on 0.8 mlBD of low molecular weight heparin, of Clexane. And 2 days later, she's in the ICU, shifted her into the room. And this is Saturday night, just 3 days ago. I'm leaving the hospital 8:30. My sister, my nursing staff sister, we'll just go see her once. I walk into the room and she's plegic. She's just finished dinner and the family is saying, so 5 minutes ago, she was fine. And I see that she's not moving one side. I rush her down to the CT scan to make sure she's not bled. She doesn't have a bleed. I see a hyperdense MCA where that thrombus was. I say that we won't waste time doing a CT angio. We know what is there. We're going to take her to the DSA lab. We take her there. We open a vial of tenectex. We've got everything set up. I'm priming the family, telling them we're going to do this. Sometime going to do this. There'll be a dislodgement of the embolus. It could go distally, this and that. And we're talking and she recovers. And she's back to 5/5 and no deficit, right outside the DSL. Then we talk and I'll take her back. And I've got this open vial which is lying with me, which I can't do anything more about. And it's there. So I've reconstituted and kept it there. Then I call up Emcure to ask them how long I can keep this vial in case she strokes again at night. So then they tell me, look, you can keep it for 4 to 6 hours after reconstitution. And nothing beyond that. So I understand. Obviously there are going to be many instances where you reconstitute something and keep it in the fridge in such a scenario. So it was a learning in many ways. Now she's fine. It's been 72 hours since then. I've still not had the courage to remove her from the ICU. I continue to give her, and I at that point of time, I just added antiplatelets for what it's worth and continued the low molecular weight and kept her on the warfarin. So she's on that now. I just was sharing this case just to tell you that I had to ask them how long I can keep the vial after reconstitution. One learning there, that's all. So
yeah, very interesting. Very interesting. I've also had this, you reconstitute the damn thing and the fellow recovers. And that thing costs 40,000 rupees.
Correct.
So what do you do?
Yeah.
So in my lecture once I'd said that if he's recovered and you've reconstituted, give it. And if you've not reconstituted, don't give it. But this is all anecdotal. There's no data on this.
So
there are some questions from the audience. Sanket, can you tell us the questions?
Yes, sir. So Dr. Santosh Singh from Raipur wants to ask, if CT scan is negative and patient acute onset of CVA within the window period, should we go for MRI or thrombolysis?
Thrombolysis.
Okay. And same doctor, sir, Dr. Singh also wants to ask, what about thrombolysis if patient is on anticoagulant? In a case of RHA, in there any cutoff mark for PT-INR?
Dr. Vijay has already talked about it. He can again reiterate.
Yes. Regarding this question, if a patient is on anticoagulant, INR is less than 1.7, you can thrombolize if it is an acute infarct and there is no bleed on the CT scan. But if the INR is more, this is what guidelines says. If INR is more than 1.7, if it is a warfarin or a direct anticoagulant, acetron, we need to use a reversal agent, give FFKs or the vitamin K, the antidote, correct it, and then bring it to 1.7, and then we can thrombolize even after that. But if it is a newer oral anticoagulant, which the patient, if the patient is on, then if the patient can get an antidote for the dabigatran and all, then it is okay. Otherwise, it is difficult to thrombolize if it is a newer anticoagulant. So there, INR has no role.
It depends when the oral anticoagulant was taken. So, suppose he has missed the oral anticoagulant for 24, 48 hours and the renal function is good, then maybe you can. So you ask when the last dose was taken, because sometimes they miss the dose. Even with warfarin, they miss the dose. It's very common. So you must ask, even for NOACs, especially, when the last dose was taken and what the renal function is. So if
new drug has also come now, sir. The prothrombin concentrate injections.
Yeah, but that's not actually. They say it is good, but it is definitely second line. It is not a proper antidote for apixaban or rivaroxaban. It's not the proper antidote. Adenostate alpha is the antidote, but we don't have it. So, and many places in the world don't have it. So, this PCC, people are promoting, people are saying it, but I don't think it is a proper antidote per se. It's a general thing, but it's not a reversal agent by no stretch of imagination. Yeah. Any other question?
Sir, Dr. Himanshu Agarwal from New Delhi, he mentions 3 comments. He says, did dissection seen on initial run or on CT angio? And the dissection may be complication of mechanical thrombectomy.
Nilesh?
Yeah, that is what Ichapuria sir also had suggested. And retrospectively, that might be the thing. Because otherwise we didn't find any most probably it was related to the thrombectomy itself. Putting everything together, it looks like she came with a procoagulant or thrombophilic state, probably a cardiac clot, and that embolized. And while very procedure, probably this dissection probably developed.
Sure.
By the way, Himanshu was with me that night outside the DSA lab. While we were opening the lab, Himanshu was supposed to do the DSA for me. And just to tell you that now that I hear that he's also sitting on the session, but he was the person who was supposed to take the person in when she recovered completely. So anyway.
Yeah.
Wait, sir, that's about it. These were the questions, sir.
Can I ask one question, sir?
Yeah, sure.
Yes, sir, actually, this patient was some 2 weeks back. She was an around a 62-year-old lady, came with acute onset aphasia, left MCA infarct, and we were just counseling her for thrombolysis. She came within, sir, not more than 1 hour, and everything was ready in next 30 minutes. She showed me an old discharge card saying that 5 years back she was thrombolized, and post thrombolysis she developed a bleed. So now shall we thrombolize this case or we shall not? Because any intracranial bleed is an absolute contraindication.
What type of bleed was it?
Sir, it was a left basal ganglia bleed, right basal ganglia bleed with residual left hemiparesis. And now she came with a dominant
bleed. It was a bleed due to the thrombolysis, or?
Yes, sir.
Post thrombolytic bleed.
Post thrombolytic bleed.
Nope. I don't know. I've never encountered this. Anyone, Rajshekar?
I think, sir, in this kind of situation, you would probably still want to go ahead and thrombolize. See, because the question out here is that she's developed a bleed post thrombolysis. Right. There must have been a sizable infarct or whatever the cause of that. There must have been some hemorrhagic infarction anyway. You've converted that into a total hematoma, but that she's recovered. But she's come with another territory. And, your other factors. So I think absolute contraindication, when you say of the IC, absolute contraindication is a person who has an IC bleed at that point. Any past intracranial bleed is still a relative contraindication to the best of my understanding. I don't think, and many of these things could be beyond 3 months, will have little relevance. So even if people had an ischemic stroke and have been thrombolized and then have come in with another ischemic stroke 1 month down the line or 2 months down the line, there's no reason not to thrombolize in an ischemic stroke, recurrent ischemic stroke. I think the same would apply to some remote bleed, which is 5 years old, with an area of... Sorry?
With the same agent, sir.
See, again, the reason why she bled was not likely the agent. I would imagine that the reason why people usually bleed in this sort of situation, I mean, of course, there is that inherent risk of having a 6% bleed whenever you do it, even in the best case scenario. But, the later you do it, the larger the infarct is. If there are any other comorbidities that are going to increase the risk of bleeding, etc., etc., etc. So many things you're looking at. I'm not sure that the agent itself is the culprit. I mean, why would we say that we don't have that many options while we're thrombolizing? And I wouldn't say that, okay, because she's bled with this agent, we will use another agent in the past now, so that, we are offsetting the risk of bleeding because of that first agent. I'm not sure that that is something that would, I don't think there's any data to support such a view. It's like, I'll give you another thing, like people, when you have an ischemic stroke, while you're on a NOAC on an adequate dosage, they'll change your NOAC to another NOAC. I mean, you have an AF-related ischemic stroke, and you're on, let's say, dabigatran 150 twice a day, and you have a recurrence on that, and people will, suppose you come with an acute event, will give you ideally daratumumab, reverse it, thrombolize you, get you back, and then change it to, let's say, apixaban. There's no data. We do it, but there's no data. So I'm looking at the corollary here and saying that because somebody's bled with one agent should not be a reason for you to worry about that agent. There's no such thing.
Actually, I did thrombolize this patient, and she's not doing well.
Okay.
But then that earlier bleed
played on your mind.
Relative said, yeah, last time also we had given the injection and she bled. So probably, so I thought, so I didn't. Another, sir, this capsular warning syndromes, which come with this TIAs, it goes. Now, the case you mentioned, they come with 0 power, they improve. They come with 0 power and they improve. And then I have, in my experience, sir, I have thrombolized one of the patients. I have given the antiplatelets, and still he landed with 0 power in front of my eyes in an ICU. So what do we do in such cases?
If you have seen the hemiplegia in front of your eyes, you should thrombolize.
Yes. So in spite of thrombolizing, within 5 minutes,
they will get it. They will improve. They may improve. They'll get it again.
Right.
That is what, this capsular warning syndrome gives you nightmares. But ultimately they do well, because the infarct usually is small. It's in the capsule, and it frightens you for 3-4 days. It gives you sleepless nights, and you should thrombolize capsular warning syndrome. And ultimately they do well and they walk home, or they walk after some time. So by and large, it has a reasonably good prognosis, and you should not be scared of thrombolizing them and giving them antiplatelet agents following.
So this one might be still not that okay.
Nilesh, I think what you're saying is very correct, and I think I understand your point of view. Sometimes these capsular warning syndrome, you can have 10 TIAs in front of you, so-called TIAs, because by the time you want to do something, they've recovered. Then you wait, you start walking away, they'll get another one. We've had situations where a person has had 20 such events, and you kept topping up the antiplatelets or anticoagulants, adding everything. I think you're right about the fact that when we thrombolize these patients, like Sir said, if there's deficit, thrombolize. If the deficit has lasted long enough for you to justify that thrombolysis. Because, if they recover within 5 minutes, and by the time you want to start it, they are 5 by 5, it becomes difficult for you in your mind to do it. But if there is a deficit which is there, and there is no contraindication, you would go ahead and do it, knowing that these are tricky things and they could fluctuate. One of the things I want to say that in all these things, what we try to do is not to reduce the blood pressure in these patients who have subocclusive or high-grade ICA disease or high-grade intracranial disease where symptoms are fluctuating. Don't pull the blood pressures down too much, because that's something the ICU tends to do automatically. ICU doctors, they see a blood pressure of 200 by 110, 120. Unless you're doing thrombolysis, don't worry about pulling the blood pressure down too much. I think that's something that we need to tell all people who have, who are dealing with these stroke patients. It's important not to overcorrect blood pressure, even if you have and we know that the criteria when you're not thrombolizing a patient with stroke is you can have blood pressure above 200 systolic. It's not a problem. 200, 220 is not a problem. So that's one thing that you must remember. Keep the head end down. Make sure that they are getting adequate cerebral perfusion using, IV fluids and not lowering the blood pressure, apart from all the other agents that you're using.
But in this capsular warning syndrome, the pathology has been thought is like small vessel hyalurolysis. Right. So in that case, the cause is probably the high blood pressure. So even in those cases, sir, won't be reduced?
I see in this sort of situation, let me look at that again, but I'm saying that high blood pressure is usually not something that plays too much of a role in this, at least to the best of my understanding. There is a subocclusive disease at that level, but to say that high blood pressure is playing a role in that active pathology at that point of time is not something, is actively causing this is not something that I'm aware of. I'll have to look at that and maybe I'll tell you the next time we meet, but I'm not aware of something like that.
And no, I don't think blood pressure has a role here, because we've seen this in so many young people, capsular warning, and it's not the blood pressure, it's some other vasculopathy, it's not BP as far as I know.
Nilesh, would you repeat that again? When you said that capsular warning syndrome, how does high blood pressure in an acute setting play a role? Tell me, please say that again. I'll look it up, but I just want to understand.
Just this basal ganglia and this internal capsule, one of the mechanical pathophysiology is because the high blood pressure, this lenticulostriatal arteries, they collapse. And they collapse, they open, they collapse, they open. And this hyalurolysis leads to this, fluctuating symptoms. And finally, it collapses and then we get a stroke. So that is how we raise hypertension. We get thalamic and lenticulostriate capsule stroke. That is what is one of the pathophysiology of this capsular warning syndrome.
You're saying that systemic hypertension results in that?
Right, sir.
I will have to look that up to say that it is affecting that lenticulostriate vessel and causing an acute fluctuation in the, the caliber of the vessel because of an high blood pressure in general. I'll have to just see whether that can happen. All right. I'll look it up. I'll certainly discuss this.
Right. And regarding this opening vial, sir, I will tell one of my stories that I had this elderly male who admitted with acute onset vertigo, and then he came with ataxia, slurred speech, and his one son was in Mumbai. So we did a CT scan and we were about to thrombolize, and we opened the vial. And that son, he insisted that go and get an MRI. So we did an MRI, and MRI didn't show any acute infarct. And so he said, don't thrombolize. This elderly, he was an elderly 80-year-old male. Now don't thrombolize. So I told that we have already opened a vial and you have signed for this consent. But he said, there is no infarct. So I said, okay. So we didn't thrombolize. Then who is going to pay for that vial? He said, I am not going to pay. Hospital said, you have indented it. We don't know whether you are used or not used for this patient. You and patient decide what to do of that vial. It was almost 60,000 of the medicine which was lying and nobody was ready to pay. Finally, I got it replaced from the company at no cost, but that is an issue which I face.
But Nilesh, one thing is very important, that in posterior fossa stroke, acutely, in MRI, you won't see the infarct. You may see it on second or third day.
Sure.
After 72 hours, you may see it. You may not see it in 3 hours, 4 hours, 6 hours, 8 hours. You do the first scan. first scan may be normal, second scan may be not, and the third scan, when you do, you may see it. So
Yeah,
you
I
must tell
couldn't,
the son that, see, so therefore, in this posterior fossa, you should do that HITS test and skew deviation, and you should do that to diagnose posterior fossa stroke.
yeah, probably
Because MRI is notorious for being normal in these small strokes in the posterior fossa.
right.
Okay, I think we've had a wonderful discussion, though there was one case, Sanket, one case we could discuss at length for 1 hour, 10 minutes. So, each case, there is so much to learn, so much to discuss, so much to talk about. And so therefore, this forum makes it all the more fascinating and all the more interesting. And, and there are so many nuances, so many questions, so many different answers. As usual, I think it was a wonderful evening. And I would ask Dr. Vijay Chenna for his last word, and then Dr. Rajshekhar. Dr. Vijay?
Definitely, sir. This being my first session, I enjoyed it a lot. The discussion with you all, sir. It was a nice experience. Dr. Nilesh sir case was also very good. Described in detail the management also. That's all, sir. Thank you. I would like to continue this if it is possible.
Yes. Rajshekhar?
Absolutely. I think that's a wonderful case presented by Dr. Nilesh. It was, as usual, a very, very educational and enjoyable session. And I think the old adage, oft repeated adage that we learn neurology stroke by stroke is very, very true for this meeting.
Yeah. Okay. Thank you so much. I hand it over to Dr. Sanket now for the final word.
Thank you, sir. I think I'll start with the comment or the words Dr. Reddy sir said in the start. Like it can be a mundane case, but there are so many nuances and anecdotes around it. And today I would see that even in one case, we spent 1 hour, 10 minutes in such good, interesting and engaging discussions that even my comments on the chat box that I see are talking about so many different ways of looking at one case, which Dr. Nilesh sir has presented. And I think the depth that he has also gone in when you asked him so many questions around it, and he had all the possible answers to it. I mean, hats off to Dr. Nilesh sir as well on that terms, because most of the time the case is a simple case, but the thought process that goes behind every case is what is the important thing. And that's what makes this platform unique. And even in one case, we had so many things that we exchanged, we learned, even the attendees came up and asked their questions, learned from those experiences. And I believe this is an everlasting field. I mean, if Dr. Ichhapuria sir wouldn't have stopped, this discussion would have kept going in some or the other. It's like a river of knowledge which just keeps flowing. So I believe the 4th episode has made its mark in the calendar, and I believe everyone would be very much engaged for the 5th as well. And I would invite everyone for the next meeting. And I would really thank our guest speaker today, the guest moderator today, Dr. Vijay Chenna sir, for actively engaging in this discussion and giving your insights to us, sir. Thank you. Thank you, our moderators, Dr. Reddy sir, our course director, Dr. Ichhapuria sir, and our presenter, Dr. Palasdevkar sir. Thank you all. Thank you and have a great evening ahead. Thank you.
Good night, everyone. Thank you again for everything. Bye-bye.
Good night. Bye.
Good night, sir.